This podcast is for educational and entertainment purposes only. The views and opinions shared are mine and my guests alone and don't represent our employers, past, present, or future. Medicine is always evolving and practices may vary. Nothing here should be taken as medical advice. Always follow your own professional judgment and institutional guidelines.
Have you ever heard of palliative care? And they say no. So usually I just, define it simply as palliative is an extra medical specialty here for support for anyone with serious illness, especially illness that could be life limiting. Okay, so we help with symptoms, we help with resources, we really help talk about the future. So that's like the very simple way that I outline it, because I think then patients are like, okay, you're not intimidating, you're not here to take over my care, we're not doing anything different. You're just here for support. And I really do think that's the best way to define what we are in palliative. But along those same lines, the biggest misconception then is that we are the same thing as hospice. So, if somebody heard that palliative is coming and they happen to Google palliative, they often are going to find palliative and hospice. And then they think, oh gosh, didn't someone not tell me that I'm dying? So it tends to be a hard misconception to break. But, right out of the gates, I always say we are not the same thing as hospice. They're separate from us. We are just here for support along your journey. So I think that's often the best way to define it. It's just extra support.
Welcome to the Beyond the Call Light podcast with Gary, the ER nurse, where we tackle the tough topics in nursing. Update your whiteboards and huddle up because this episode begins now.
Hey, it's Gary, the ER nurse, and welcome back to another episode of Beyond the Call Light. Today's guest is Chelsey, the palliative care PA. I found her on TikTok, and her educational videos about palliative care were just phenomenal, especially from somebody who works in a hospital and doesn't have much experience with it all, except for the patients that come in who are receiving palliative care. So I thought it'd be great to have her on to kind of help us demystify all of that stuff that comes in that we may not deal with. So we're going to start out and let Chelsey just introduce herself and tell us a little bit about her background.
Thanks, Gary. It's great to be here. So my name is Chelsey Ernst. I'm a physician assistant. I have been a PA for 10 years now. I did most of my work in internal medicine outpatient, actually, but I also did some hospitalist moonlighting. So I had some palliative experience at that point too. But I've been in palliative care for 2 years. And when I joined palliative, I immediately just fell headfirst in love with this specialty. I fortunately had a couple of really wonderful mentors, and they guided me into learning about the specialty. And I think as a PA in general, it's really important in any field you end up in to have a good mentor, because we get general knowledge from school, but we don't get the specialty knowledge as much as, as someone who goes to a fellowship or otherwise as a physician. So fortunately, I learned pretty quickly. I love learning. I listen to lots of podcasts. So that's why I was like happy to come on a podcast, of course. So it's been a really cool journey. And then I realized there's this big gap that really nobody knows about palliative care. Even coming from internal medicine, I didn't know all that much about it. So that's when I kind of started my whole social media journey as well, to spread a little more knowledge, just so it's out there for everyone, not just myself.
Well, and I think just watching your account grow in a very short period of time just shows that there is that desire to know more about it, especially from clinicians as well as just family members who may be dealing with some of these complicated medical issues. So let's get right into it. Let's talk about the big picture. Let's start with, how do you define palliative care, and what is the single biggest misconception that you encounter from other healthcare professionals, especially those of us like myself who work in an emergency department?
Sure. So I'll tell you kind of just how I define it to my patients, because most of the time when I walk in the room, I say, hi, I'm Chelsey, the palliative PA. Have you ever heard of palliative care? And they say no. So usually I just, define it simply as palliative is an extra medical specialty here for support for anyone with serious illness, especially illness that could be life limiting. Okay, so we help with symptoms, we help with resources, we really help talk about the future. So that's like the very simple way that I outline it, because I think then patients are like, okay, you're not intimidating, you're not here to take over my care, we're not doing anything different, you're just here for support. And I really do think that's the best way to define what we are in palliative. But along those same lines, the biggest misconception then is that we are the same thing as hospice. So, if somebody heard that palliative is coming and they happen to Google palliative, they often are going to find palliative and hospice. And then they think, oh gosh, didn't someone not tell me that I'm dying? So it tends to be a hard misconception to break. But, right out of the gates, I always say, we are not the same thing as hospice. They're
Mhm.
separate from us. We are just here for support along your journey. So I think that's often the best way to define it, as just extra support.
So as a physician assistant specializing in palliative care, what unique skills or focus do you bring to that interdisciplinary team? You talk about coming into the patient room, they're already being seen by other physicians and other medical specialties. So like what is your skill or focus that you bring to that team? And what does a typical day look like for Chelsey?
Yeah, sure. So a lot of times my team is consulted on like the inpatient service or in the ER when somebody is really in either crisis mode and they need to have a conversation and redefine what their healthcare goals are. Now, that's kind of the big thing that I think palliative brings in is just conversation. And that might sound really silly, but I always say that conversation is our procedure. Everybody has their procedure. Cardiology does catheterizations, general
Hmm.
surgery does appendectomies. We do conversations about serious illness. And they're hard conversations. So it's something that, even someone coming who had 8 years of experience, I didn't know how to have these conversations very well. I would have them at times with patients I knew that were really sick, just saying, like, we need to start thinking about what the future might bring. But actually sitting down and having a structure for these conversations makes it a little bit easier to get through them. And also, being just an extra piece of support, not only for the patient, but for the team.
Right.
Because a lot of times that's really the big thing is the team is uncomfortable sometimes with a situation where either someone is coming back to the hospital recurrently for an illness and they're starting to question, are we doing the right thing? Would this person even want to come back to the hospital? And in the ER, same thing. You guys see patients over and over and over again for
Right.
heart failure exacerbations, COPD flare, all of these things. And it's kind of like, wow, something needs to change with this person's care. How do we even start that conversation? So I find that's generally where we get brought in is like, here's some extra support. Let's talk about these things.
That segues nicely into the next question. And you talk about when we get these repeat patients that come in with chronic medical problems and we can't seem to get the treatment plan right. And that's why they keep coming back. So, from your perspective, at what point in a patient's serious or chronic illness trajectory should an ER team, like myself working as part of a team, or an inpatient team, when should we consider consulting your specialty?
So I feel like there's a couple specific things that come to mind. One is definitely the repeat patient. I mean, somebody who this illness is likely going to eventually take their life. And that doesn't necessarily mean it's going to be tomorrow, this month, this year, but even something like COPD, we know it's going to continue to worsen with time,
Right.
even if that's 10 years down the road. So if they're coming in over and over again, sometimes it's worth just bringing us on board because then we can ask the question of, what extra support do you need to make you have success at home when you leave the hospital? Because sometimes those are the pieces that, like, you guys in the ER or even the inpatient team don't have time to necessarily sit down and address. Like, well, what does your home life actually look like? When we send you out of our ER, what are we actually sending you back to? And do you
Right.
have any of the supports to help you take your medicines that we're even giving you, or, help make sure you get the oxygen that you need when you're at home? Just those pieces. And I think that's really where you can start thinking about palliative because we can definitely help coordinate some of those pieces. And
Hmm.
also, that's a huge part of our role is just sitting down, getting to know this person and their family and their home life and figure out like what's going on with everything, not just this piece, not just your COPD, but your whole life, your whole story. And how do we figure that out?
Right. That holistic approach, not just the treatment for
Exactly.
today, but and that's the thing that we see in the emergency department. And I'm fortunate where we work, we have a nurse navigator who kind of helps manage some of that. So like, do you have
Definitely.
access? Do you have somebody that can get you to your appointments? Do you have somebody who can pick up your medications? Is there somebody checking to make sure that you're taking your medications? Those kind of things. Now, this next question I initially had written, and then after hearing you speak already, I've decided I need to change this. So initially, I was
Sure.
thinking about because again, comes from my misconceptions of what palliative care is, and so initially, I was going to ask beyond patient survival. How do you measure success? But I think I would retract that because that's not necessarily how you would measure success. So, from a palliative care team standpoint, what is your measurement of success for your patients?
Yeah, and this is such a good question that I feel like I was struggling to almost define myself because you're right. So interestingly enough, there have been studies that have shown palliative care patients actually have better survival rates. So that's one huge win for the palliative world is like even though we're focusing on helping quality of life and sometimes comfort, things like that, there's actually improvement in survival if you're following with palliative. And maybe it's because of the coordination of care and things that we do. But I think some of the big pieces for us as a team is we're specifically looking at, which is not a measurable thing, which is the problem for healthcare systems, but how much can we improve someone's quality of life? If they come in to see us for the first time, and we've had patients that come in absolutely miserable. They have severe pain from their cancer. They're vomiting all the time. They're not sleeping. They're not able to get off of their couch. If that's the person I meet the first day, and then a month down the road, their pain's under control, they're sleeping better, they're enjoying time with their family, that's a huge win. And like I said, that's not something we can necessarily measure, put that on a scale of 1 to 10 or something like that. But from our perspective, we're seeing it in real time. The other thing that a lot of times is a measurable outcome that is still one of those hard to measure ones is hospital admissions, like readmissions. So a lot of times that's one of the things that hospitals as a system look at of if they have the capacity to bring on palliative care is okay, we want to hire these people that we know are going to be really helpful and supportive, but how do we actually measure how much they're making a difference? And a lot of times those are the things that they're trying to do. Well, if we have these patients with very serious illness, how many readmissions do they have after they've seen palliative care? Are they helping to keep them out of the hospital? Are they helping to, guide resources, things like that?
I almost feel like I should have led with this one because this is, I feel like for me, the biggest misconception. You touched on it earlier, but what is the fundamental difference between palliative care and hospice? Can you,
Yeah.
I mean, I know you get this
It's
question a
the
lot,
million
so I'm just
dollar
going
question,
to,
right?
that's right. So I'm just going to let you answer it the way I'm sure you've answered it 1,000 times.
So, a lot of times you'll hear people explain palliative and hospice as palliative care being needs based and hospice care being prognosis based. But what
Okay.
does that even mean? So, essentially, the biggest difference is hospice has a set of criteria, specifically that we think someone likely has less than 6 months to live.
Okay.
So, if someone has a specific, say they have heart disease or lung disease or cancer, there are literally a list of criteria that you can find that are hospice criteria. And if someone has those criteria, they meet that they can go on hospice because we think they could have less than 6 months to live. If they don't meet those criteria, they're not hospice appropriate yet.
Hmm.
On the other hand, palliative care, we don't care what your prognosis is. You could live months, years, decades, it doesn't matter. We can see you no matter how long you may live. And that's the big difference too is hospice patients absolutely have a terminal diagnosis because we
Okay.
expect them to die.
Hmm.
Palliative patients, on the other hand, a lot of times these are life limiting illnesses, but we also see cancer patients who are very likely to be cured. So it's kind of a difference of, we can see patients for a long time, years even, and sometimes people like to use the word graduate. I don't know really how I feel about that term, but they can graduate from our services and they may not need us again in the future, especially if they have a cancer that doesn't come back. So it's kind of an amazing world to be a part of.
And that already answered the next question, which was, can you receive palliative care while still seeking curative treatments? And you've already answered that, and the answer is yes, you absolutely can.
Yes,
So
absolutely.
let's move on to prognosis and timing. So as I understand, and as you just explained, hospice has very specific requirements, and
Mhm.
the 6 months is what I had heard. So it's good to hear that you validated that. And does palliative care have any time-based restrictions at all? You kind of mentioned that a little bit, but I think that's still a very common question. Or is it just purely based on the burden of the illness?
So I feel like this is something I've even struggled to define a little bit because there's not a specific time frame. So for example, someone with congestive heart failure that is struggling with symptoms and recurrent admissions, there's not a time frame. We don't know how long this person could have left on this earth. But a lot of people say, you guys see serious chronic illness, and why don't you see people with rheumatoid arthritis? Or why don't you see people with Crohn's disease or, those sorts of things? Because they
Hmm.
are also serious chronic illnesses and
Right.
also affect quality of life. The difference is rheumatoid arthritis and Crohn's disease, if they are well controlled, they are not technically life limiting, and they can be well controlled if you have a good rheumatologist or you have a good GI doc or whoever it might be. Um, but when you have something like COPD, dementia, CHF, something like that, liver disease, we know those things are going to progress. There's not really a course of action that you can take and be on a medication that's going to halt that illness or essentially
Mhm.
really treat the underlying cause of what's going on necessarily. So especially when you get toward an end stage condition, COPD that becomes to the point that oxygen isn't really working anymore, or liver disease to the point that people are really filling up with fluid in their belly over and over again, like with
Right.
ascites.
Yep.
Those things, there's not going to be a magic cure for those things. And those are
Mm-mm.
really the patients that we can see, though we know, like I said, there's no timestamp. Someone with cirrhosis can live for a decade or more,
Mhm.
but they might have a lot of symptoms. And sometimes we'll coordinate with their other providers to try to help those symptoms as best as we can.
When you are coordinating this with these other teams, do you ever get any pushback from them, or are there any conflicts in terms of like what your goals are and what their goals are? And if there are those conflicts, how do you manage those?
That's a great question. So, I think the biggest pushback we find is still when people just don't understand palliative very well. So, they start to think we are hospice and we are going to push for no treatment. And as soon as we come in and we say, "Hey, if this patient wants everything, that's cool with me," then the
Mhm.
specialists are usually a little bit calmer. But at times, there've definitely been patients where I talk to the patient and their family, and they're saying that they don't really want this aggressive care, but the specialty team is coming in and really pushing for things like dialysis or, multiple taps of the lung or biopsy for a cancer, something like that. Because
Mm.
in our mind, as the medical team, we think if there's something to fix, we should fix it.
Absolutely.
I mean, that's just ingrained in all of us. So,
Right.
so sometimes that's when I'll actually kind of pull the specialist aside myself and just say, "Hey, I think we need to either meet with the family together so you can hear what they're saying as well, or
Mhm.
let's talk about this a little bit more and talk through, where you're coming from, what I've heard from the patient's family, and how do we kind of figure out what's best for everyone." So a lot of times once, even coming from somebody who used to be a specialist, once you actually figure out, oh, this is what the patient wants, and we don't need to get the biopsy. It's just what we want as the medical team,
Right.
then we can kind of do what's best for everyone. It is
Right.
it is a tough barrier to break down though, for sure.
Now, do you think I'm kind of getting off topic here, but these questions are just bringing up more questions. Do you think
Yeah.
this is something that maybe we need to address like earlier in like these medical professionals' career? Like, do we need to start incorporating this more heavily into medical school or into their residency so that it's not so foreign to them when they actually get into the practicing world?
Yeah, I think it is super important, and that's actually one of the reasons I started, like, my social media journey was, like, I was like, "Other doctors and providers need to be trained on this stuff." Like, we can't always just be so, like, full steam ahead all the time because sometimes we're suggesting these things, but we're not really thinking about if our patient actually wants these things. So
Right.
it's definitely I think it's worthwhile to talk about early. I think there are some programs, like I don't know if you've heard of Vital Talk or anything. This is like a
Mm-mm.
conversation style program that's out there that I think a lot of physicians have in training at some point.
Okay.
But it's like a one-time thing, and it's like, here's how to have a serious illness conversation, and here's a structure you can follow. But who actually remembers that then when they're actually talking to a patient's
Right.
family?
They're too
It's
busy remembering the Krebs cycle. They don't have room for that.
yeah, there's so many other things on our minds. I mean, that's exactly it. And sometimes it's like we have to take a step back and be like, okay, we're also science minded and
Mhm.
treatment minded, but then we need to refocus on the person that's in front of us. And it's like, this person is a human, as silly as that sounds. This is not something to be fixed all the time if they don't want us to
Right.
put them through this stuff. So, yeah, it should be. It absolutely should be incorporated more.
Now, can you walk us through a scenario where a patient begins with palliative care and then seamlessly transitions into hospice?
Yeah.
And what factors typically drive that decision?
Sure. So I think probably one of the easiest examples would be someone with cancer.
Okay.
Okay. So a lot of times with like my palliative service in particular, we have outpatient service as well that we do in our cancer center. So a lot of times it's nice because we're meeting our cancer patients the same day they're seeing their oncologist. If they're having pain and symptoms, their oncologist says, "Hey, we have this team for extra support and to help you with your cancer pain. Go see them." So we'll meet them. We'll start getting their symptoms under control. A lot of times this is during their journey where they're still receiving chemotherapy, they're still receiving radiation, they're getting all the scans and everything. And then eventually, if there comes a time where either treatment isn't working anymore, or they've kind of failed all of the things that are out there and there aren't options, or they get to a point that they're just not tolerating treatment and they say, "I don't think I really want to do this anymore."
Mhm.
That's kind of where it's nice that we already know them, because then we can help guide them as to when the right time for hospice is. And a lot of times the right time for hospice is whenever someone doesn't really want to come back to the doctors anymore and when they
Mhm.
don't really want to go back to the hospital anymore. So, because it's a big question of like, when do I stop seeing you, being me, the palliative provider, and go
Right.
on to hospice? And that's a lot of times the one piece that I pull out is, if something happens today, are you okay coming back to the hospital for treatment? And if you say, as long as I would have symptom management at home and somebody to call if something goes wrong, I probably just want to stay home. I don't even really want to come back to the hospital. I think that's an
Mhm.
awesome time for hospice. And that's usually when we'll start getting them involved.
Quick break from the conversation. If you're enjoying Beyond the Call Light, please don't forget to follow the show wherever you listen. You can find us on Spotify, Apple Podcasts, YouTube, and Amazon Music. Hit that follow or subscribe button so you never miss a new episode. And if you're on Apple or Spotify, a quick rating or review really helps others find the show. Speaking of which, let's get back to it. This is something that I've heard, and I'm going to rely on you because you're the expert here. I've often heard that all hospice is palliative, but not all palliative is hospice. Sorry. One, is that accurate? Two, what aspects of your palliative care practice are still fully utilized once that patient moves into hospice?
Yep, I've heard that too, and I actually use that phrase sometimes. So,
Okay, good.
yes. So, essentially, what that means is palliative and hospice both have the same focus, which the focus is on the patient
Hmm.
and their goals and their quality of life.
Okay.
Okay. So, that ideally, even if someone is going for aggressive care in palliative care, we are still focusing on their quality of life and talking through the other things that no one has time for, like we talked about. But so once we're doing pain management, symptom management, trying to get them resources, trying to get equipment in their home that they need, these are all things that palliative can do. Hospice can absolutely do all of those same things. So
Hmm.
hospice, I always say to my patients that I'm transitioning to hospice, I always say hospice is kind of like palliative on steroids because they do what we do plus more.
Right.
So they will still do all of the symptom management. They will bring any equipment someone needs straight to the home and cover it under the hospice benefit. So that's the other thing. There's not like jumping through the hoops of insurance like we still have to do in palliative care.
Right.
And they also bring nurses straight to their home. There's someone on call 24/7. I always say I can't be on call 24/7, but hospice is on call 24/7. And they really just provide so much more and bring it straight to their home. So that's where
Yeah.
a lot of times I will be like, "Hey, I think it's time for hospice because they can do more for you than I can do at times."
We've used hospice in our family on my dad's side and my wife's side, and it has been nothing short of amazing. It's an amazing option if you have reached that point with a family member. So we've had nothing but good experiences for all the reasons that you just stated. Now, how does your team ensure that continuity of care when a patient is receiving palliative care service while also managing their diseases with all the specialists, like you mentioned, oncology, cardiology, GI, all of that stuff? How do you guys work together to make sure that you're all on the same page?
Yeah, so fortunately, where I work, we all have Epic and we all have Tiger Text, which are just two things that, Epic is a great EMR in the sense that we can literally like message the specialist within the record if we want to and link the patient's chart. So it's like if I have a question, I can directly message their other providers and even include everyone in a group text essentially if I want to.
Hmm.
So the challenge comes in when someone, say, for example, has heart failure, because there are so many symptoms in a heart failure exacerbation, being like shortness of breath, leg swelling, fatigue, all of these pieces of the puzzle, that a lot of those are not something I'm just going to cover up with a medicine. Those are things that actually need to be treated by their cardiologist. And that's where if they're having those symptoms and they're in my office, I will message their cardiologist or call the office if I need to say like, hey, this person's having an exacerbation. I think we need to, we need to get them straightened out. But also, it's nice to be the middle person for the patient because it can be super overwhelming for the patient to think they need to call their cardiologist every time or they need to be the one coordinating, every time something goes wrong. They feel like a pain, I think, to their specialist, which sounds sad, but I think that is the case. So sometimes it's
Right.
easier for me to be the one to be like, I'll reach out, we'll start coordinating some medications, we'll let you know.
Right.
Because as everybody knows, there's these big call centers that you have to call into and go through 20 prompts before you even get to a nurse. So it's nice that my patients can just say, hey, Chelsea, I'm having this problem. Can you call my cardiologist? And I'm like, yeah,
Right.
absolutely. And it's nice because once we get these relationships with a specialist,
Mm.
they're great. I feel like I haven't really had any specialists that have given me too much pushback about trying to help their patients because we're all here for the same thing, which is to help our patients.
That's wonderful. Yeah, that's great to have that
Yeah.
kind of that team working all on the same page. So now, from an ER perspective, which is what I do, I work in an emergency department, and we
Yeah.
frequently get these patients that come in who are either on hospice or receiving some level of palliative care. So, from my perspective, when that patient comes in and is either on palliative care or hospice or both, what is the single most important piece of information that we can look for to help guide our initial treatment and then our disposition plan? Like, what point do we reach out to you? I know oftentimes we have to reach out to the hospice nurse because there's rules about suspending care, especially if they
Yeah.
get admitted.
Yeah.
So we have to reach out to them. But I don't think I've ever had to reach out to a palliative care specialist for that patient. What do you recommend?
Right. So essentially, if they're with us in palliative, because we are not changing the entire course of treatment necessarily, I would say most of the times you could treat them exactly like you would any other patient. Now, that depends because, the things I would specifically look for would be if they have an advance directive on file, if they have a living will on file, if they have a pulsed form, which is ours in Pennsylvania. I don't, everybody has a different version of this form. But
Hmm.
essentially, these forms all help figure out what is this person's goal with their healthcare. Okay.
Okay.
Um, so, like I said, in palliative, they may still be doing all of the aggressive things, other than, say, if their heart stops, they're not going to have CPR, those sorts of pieces. But, and you can still be a full code on palliative. I always say, like, that's, that's another misconception that we can get to
Oh,
later,
good.
maybe. But, the other thing is with hospice care, you're absolutely right. So it's different because if someone came in on hospice, usually the first call should be the hospice agency because the first question should either be, is this something that we need to admit this person for symptom management under hospice services? Or is this something that's happening that we're actually revoking hospice
Hmm.
and going to treat aggressively for now and then potentially go back on hospice later? So,
Right.
for example, if somebody falls and breaks their hip at home, hospice isn't going to just say, oh, we'll treat it with morphine, just stay home. Just stay, they're going to say, go to the ER, get your hip
Right.
fixed, have surgery if you need it, and then come back if, once you're done. So I definitely would say in the ER setting, first call would be the hospice agency just to be, or the family member, maybe both, to
Right.
say, what's the plan? Are we seeking kind of aggressive care today? And that's why we're here. Because sometimes it's even someone is having seizures at home. Someone is having a pneumonia that they might need IV antibiotics for, something
Hmm.
like that. They still might land in your ER because sometimes the hospice has already tried multiple things before they get to your ER typically. So, yeah, it's a little different with hospice. In palliative, I would say a lot of times you don't need to call us first unless it's one of our cancer patients and they're having pain crisis. I would say that's
Okay.
the huge time that I would definitely encourage you call the palliative team because we already probably have a pain plan for this person. And we're going to tell you whether we think we need to push to get them admitted for pain management or we can get them out of your ER with a change in pain management. And we're going to help you with that.
Okay, that's good to know. That's
Yeah.
what I was looking for. Now,
Yeah.
you mentioned about, the do not resuscitate, which leads into the next question. Can you explain the difference between having an advance directive and you talked about a care plan and a formal goals of care conversation with the palliative care team?
Yeah. So I feel like there's so many pieces to this question. But so first piece that I always stress is that an advance directive is an umbrella term encompassing all these other pieces, which are a
Right.
living will, healthcare power of attorney, sometimes a form stating that you're a DNR. All of those pieces are kind of this umbrella of advance directives. So most people know advance directives to be a living will. Okay, so a living will is a form that essentially says if I end up in a terminal state where I have brain damage, I'm unlikely to wake up, I'm in a coma, what do I want and what do I not want? And to be honest, Gary, most of us say, I don't want anything. If that's the case, pull the plug, let me go.
Right.
I think that's what a lot of people say. But the interesting thing about a living will is it has nothing to do with today. If I'm not in a terminal condition today, even if my living will says in that state I would be a DNR, in that state I wouldn't want dialysis, that doesn't mean if something happens today and I'm relatively well today that I wouldn't want CPR. So there's definitely a misconception there that if a living will says that, that's what they want right now, and that's not necessarily the case.
Right.
So that's kind of an important point to always bring up, because people will be hunting for the living will when we're talking about code status, and I'm like, the living will is kind of a guide. It's not really an end all be all.
Right.
So yeah, and that's really where these other conversations come into play. Because
Yeah.
I know if someone has had a code status conversation, a goals of care conversation with me, we're trying to put it in writing in some way, shape, or form because one, I'm assessing if this person can actually make their own decisions. So, one of those pieces that you guys, of course, I'm sure deal with a lot in the ER is decision making capacity.
Yes.
Just like if someone is actually able to make their own healthcare decisions or not. And that's a piece that if I'm talking to someone, I have assessed for that. And I know if we put it in writing, this is what this person wanted. So I know for sure, and their family can go off of this in the future. Now, what do we do with that information is always the next question.
Right.
If there is something like a DNR form for your specific state, then
Mhm.
that's what we would try to fill out. If someone does not want CPR, is make sure it's in writing, it's signed by a physician or a provider, and we know for sure that the person had capacity to make that decision.
Now, for these forms, you talked about the interdisciplinary team. You guys use all the same systems, and that's great. But that's not always how that works for us, right? So when
Right.
these patients come in, they may have a plan, but we may not have access to that. Do you recommend that families keep a packet together that has all of this information? The durable DNR, we use a durable DNR in the Commonwealth of Virginia. Their
Yeah.
advanced directives, their pain management plan. Do you recommend that they carry this with them anytime they may have to go to the hospital?
Yeah, so in Pennsylvania, our form is, like I said, called a pulse form. It's very similar to the durable DNR. It's bright pink, and I always tell
Okay.
them, "This is a form, it's bright pink for a reason. It's important." So you
Mhm.
take this with you when you go to the hospital. If the ambulance shows up, you hand it over to them, all of those pieces. So we do try to really explain that these are the forms you should have with you, and you should
Okay.
make sure they're on file wherever you seek healthcare. It's usually what I say. I'm like, all of the places you go, including your PCP's office. But it's tough because we know in reality, like we can say those things all day, but that's not always the case. You sometimes have people show up in your ER that there's no record. You don't even know this person at all. They've never been
Mhm.
to your ER or your healthcare system. So then we're kind of starting from scratch, and that's
Right.
definitely a harder place to start.
Now, can you explain the difference between having an advanced directive, and then say like a living will? You mentioned that a little bit. Can you go into a little bit more detail about those two things?
Yeah. So, like I said, advanced directive kind of includes everything like a living will, a healthcare power of attorney. Advanced directives is a term that just means any forms relating to your end of life wishes.
Okay.
Okay. So it could be if someone says, I have an advanced directive, they could mean any of those things. They could mean I have a DNR signed, I have a living will, I have a POA. So that it's kind of clarifying what do you actually have when you say advanced directives? What have you
Okay.
filled out? Let me see them so I know what's filled out. And I always say the really important pieces are one is a healthcare power of attorney. So
Okay.
sometimes a living will and a healthcare power of attorney are a combined form. So, like, our system uses a combined living will and healthcare power of attorney form, which is great because then it's like all the pieces of the advance directive in one.
Hmm.
But that's not always the case. So, if they have a living will, you want to say, okay, does it have a power of attorney on it or not? And specifically with healthcare power of attorney, people start to get worried because they say, I'm not going to sign my life away to somebody else. People do this with money, with a POA
Sure.
for finances too. They say, I'm not giving my money to somebody else to do whatever they want with. And I always like to remind people that this does not come into play unless you cannot make your own decisions.
Right.
So if you are perfectly well and clear minded, this form never matters.
That's right.
But if you come in and you're confused, or God forbid something happens and you are in a coma or you're on a ventilator, this form tells us, who do we turn to help us make your medical decisions.
Right.
So it is super important. And I always encourage my patients, sick, well, anything in between, you should have one of these,
Right. Yeah.
because if you care about who makes your decisions, you should have one of these.
My wife and I both have all this, and we've been through the legal process. For those that have not, one of the questions that we get a lot is, yes, this person has a medical power of attorney. They also have a set of directives that they have laid out legally that they wish to have done or not done if they become incapacitated, right? So let's say they're on a ventilator and they have expressed their wishes in writing. They don't want to be on a ventilator, but you still have a medical power of attorney. Let's say the
Yep.
medical power of attorney says, I'm the POA. I want to get rid of that. I say, leave them on the ventilator.
Yeah.
What do we do with that information?
Unfortunately, this does happen. And I know you bring this
Mm,
up because this does happen.
that's right.
So I think the first thing always is to actually try to get everyone together, being the healthcare power of attorney, any other family members involved, us in palliative, if able, the healthcare team, and sit down and have a conversation about, what are we missing? What are we expecting to happen? What are we hoping for, that as to why we're trying to go against your loved one's wishes? And this becomes an ethical dilemma. So I think next time, get an ethicist on too. They might have more info than I do. But really, I think a lot of times, once we can gauge understanding and fill in any knowledge gaps. That's one big thing. I think sometimes the family's coming in because they think we're just pulling the plug on their loved one and we haven't tried everything and they're hoping for the miracle and all of these pieces. And we can appreciate that. We were hoping for a miracle too sometimes. But once we get to a point where we're like, these are the pieces that we have tried. These are the facts about your loved one. These are, it's very unlikely, or there is no likelihood that they are going to come off of this. This will be a long-term situation.
Mm,
Bringing that form in, bringing it up, saying, your loved one did put this in writing for you. This was to make this decision easier for you if this ever
right.
came to pass. And it's interesting, when I've been in these situations, you almost see the room melt. Like, you see the loved ones just kind of melt when they realize, okay,
Mm,
these are the things that, yeah, this is not going to get any better. And I really don't want to go against my loved one's wishes. But these are hard. I mean, these are really hard because people are a lot of times grieving. They're having almost anticipatory grief. And it's big and it's loud. And it's sometimes hard to almost, get anything through at that point. But that's why we really need to sit down. We need to sit down and have this conversation.
well, again, this ties into the next question. Those tough conversations. What is your approach or philosophy when you have to start this difficult conversation with a family member who has widely unrealistic expectations about their loved one's prognosis?
Yeah. So I think, this is typically what we call family meetings. In palliative, we're notorious for these family meetings. It's something that, first of all, is a pre meeting with the team. So, meaning, get everybody together that is taking care of this person and make sure we are all on the same page. Okay. Because if we're not all on the same page, then it's going to be even more confusing for a family that's already struggling in a situation. So, kind of going through everything initially, saying, okay, what do we think the family may have questions about? And let's make sure we know the answers before we go into these meetings.
Right.
And then make sure all the main players from the family are there too. If there's a grandma who's coming in, or a son or brother who's coming in, make sure they're there before we have this meeting, or we're going to have to do it again and again. So kind of like organizing it first. And then when we get into the meeting, I always, first of all, introduce everyone in the room, because when we know who everybody is and we have everybody's names, it's easier to address people specifically. So if I
Hmm.
don't know the son's name and he's brewing in the corner about something, I can't be like, hey, Jared, what's going on over there? I see that you're struggling. Tell me what you're thinking.
Right.
So that's a big piece that not everybody does. You like run into the room and just start
Yeah.
blabbing. And that's what we do in healthcare, but
Right.
these situations are different. So then the very first thing we always do, I always specifically do, is just say, what do you guys know about what's going on? And then we, the healthcare team, can fill in any gaps. Because it's amazing when we hear out loud what they're seeing and thinking, we actually get a lot of insight into why are they feeling this way? Why are
Hmm.
they feeling like there's hope? Why are they, where's the gap? And when we can kind of fill that in specific to what they already know, it makes a huge difference. Huge difference. So that's like a little trick that really makes a huge difference, is listening before talking.
All right. Something we could all stand to practice a little bit
I
more.
know, I know.
All right. So I'm down to my last question. And that is from a very selfish point of view, the ER nurse. We often get one chance in the ER to discuss end of life wishes, and not necessarily the ER nurses. Sometimes we come in after a physician has been in and talked to him, kind of help process all this information. But from an ER standpoint, we get usually one shot at this. What is maybe a simple phrase or a technique? You just kind of mentioned that a little bit, but when you're like, we need to quickly assess a patient's known goals of care before they get involved with palliative care. What is something that we can do to kind of help with that transition before they come to see you?
Yeah, so same thing. When I read this question, I was like, this is pretty broad. This is a tough one because I don't know there's one perfect answer. I think the first thing to do is, like you said, sometimes you're like trying to figure this out after they've soaked in a lot of information, after the
Mhm.
doc has already been in there, whatever it might be. And sometimes the best thing you can do initially is just acknowledge that this is difficult. Be like, there's something called wish worry statements that I use a lot, being like, we wish we had better news, but we worry things are going to continue to get worse. And if that is the case, what do you hope to do with the time that you have left?
Oh,
And it's amazing that simple little piece can a lot of times open up the door to someone being like, well, if I only have, weeks or even a couple months left, I don't want to spend it here in the hospital. I don't want to spend it in the ER every other day. I want
right.
to spend it at home. And then for you, you can say, well, there's actually a program that can help you do that if that's what you want. And that program is hospice, or that program is palliative, and we can help guide them to hospice. But that's a lot of times that is just recognizing that there's emotion in the situation, saying out loud that time might be limited. And if time is limited, where do we go from here?
Wonderful. That was exactly the answer I was kind of hoping for. I know it was
Yeah.
a broad question. I know it can be unique to every single patient, but I was hoping
Yeah.
for a little something that we can kind of take away from this. Is there anything else about palliative care that you would like the listeners to know about?
I would say a couple of just broad things. One
Mm.
would be, if you think about palliative and you think this patient may benefit from it, bring it up. Okay. As silly
Okay.
as that sounds, but just talking about it is one way that we get palliative care for more people. Because, sometimes, I actually had someone on my social media the other day who said primary care doctors should be talking about this sooner. And I was like, I agree with that. I think
Yeah.
primary care should be talking about this sooner. But I also think this is not just the job for the primary care doctor. This is all of our jobs, to get people better care, to have
Mhm.
people have better quality of life. So if you are thinking about palliative or hospice, at least just planting a seed.
Okay.
Even if, it's not like, hey, do you want hospice care? It's like it's like planting the seed of, hey, there's this extra team who could really help support you. Maybe we could get them involved, and just kind of putting it out there, because the patients usually have never even heard of it, which is kind of the amazing part. Like I said, they get to
Wow.
me and they still don't know what I do sometimes, and then I'm, which is fine. I'm always happy to explain. But yeah, and just kind of knowing that, we can get involved at any point in these illness journeys. Sometimes we really are meeting people when they're in crisis mode at the very end. And we're happy, of course, to help in that situation. But I love when I can get to know somebody for weeks, months, years before they hit crisis, and then we can have already planned for that. And that makes you guys' job a heck of a lot easier then when you can look in the chart and say, hey, Chelsey already saw this patient. We know they don't want CPR. We know they don't want, to be on long-term machines, whatever. And know that's going to be hopefully a little bit easier of a situation then for you too.
Wonderful. Chelsey, tell people where they can find you and get more information from you and your specialty.
I'll tell you about my stuff, but I want to put some plugs out for palliative in general. So there's something called the Wisconsin Fast Facts of Palliative Care. And these are really important, just snippets of information about the things we do in palliative, especially like ways to treat symptoms, ways to manage pain, especially in cancer, those sorts of things. So wonderful resource for providers. CAPC, C-A-P-C, they have wonderful courses that are really just general palliative care. They're really good even for like the primary care providers or anyone who wants to learn a little bit more about how to deliver palliative care and sometimes the conversation styles of palliative care. Now, in regards to me, I always jokingly say, find me on your favorite social media platform because I've tried to cross-post everywhere I possibly can. So I am on TikTok, Instagram, Facebook, and YouTube, all under Your Palliative PA. So find me there.
Chelsey, thank you so much for coming on the podcast and talking about your specialty and how we as other interdisciplinary teams can help support you and your patients so we can get our patients to where they need to be in their journeys.
Thanks so much for having me, Gary. This was really fun.
As always, please be kind to others, be kind to yourself, prioritize your mental health. I'm Gary, the ER nurse, and we'll see you on the next episode.
Thanks for listening to Beyond the Call Light with Gary Cope. Don't forget to clock out.